This lecture will be a quick overview of hemoglobinopathies with an emphasis on how they are detected on high-performance liquid chromatography, or HPLC, and on hemoglobin electrophoresis. We'll start with a recap of hemoglobin synthesis. Red cells are almost entirely composed of hemoglobin. Hemoglobin is a tetrameric protein, meaning it has 4 subunits. In normal adults, 2 of those subunits are alpha globin chains. And the second pair of subunits may be either beta chains, as in the case of HbA, delta chains, as in HbA2, or to a lesser extent, gamma chains, which form fetal hemoglobin, or HbF. Each subunit is composed of a heme molecule and a globin amino acid chain. Heme is the product of iron in its reduced ferrous state, that is Fe2+, combined with protoporphyrin. The diseases shown here in red are shown where they interfere with hemoglobin synthesis. These images show the timeline of globin chain production from intrauterine life into adulthood. Embryonic blood cells are initially produced in the yolk sac and are primarily composed of zeta globin chains and epsilon globin chains. In early second trimester, the liver takes over as the main hematopoietic organ, and zeta chains are replaced by alpha globin chains. Epsilon is replaced by gamma globin chains, and the combination of alpha and gamma globin subunits is what forms hemoglobin F, or fetal hemoglobin. In the third trimester and into adulthood, the bone marrow is the primary hematopoietic organ, and fetal hemoglobin production peaks and remains elevated until about 6 months after birth, when HbA then comes in and predominates as the main hemoglobin form. Again, the embryonic subunits are the zeta and epsilon chains. These are very unstable and are not produced past the first trimester. The globin chains we are likely familiar with in infants and adults include alpha, beta, gamma, and delta. Alpha globin genes are located on chromosome 16, with 2 genes on each chromosome for a total of 4 genes. The remaining globin genes, beta, gamma, and delta, are on chromosome 11. Each of these have 1 gene locus on each chromosome, for a total of 2 genes each. The table on the bottom here shows a comparison of the percentages of HbA, HbA2, and HbF in the neonate and the adult. In the neonate, HbF predominates until about 6 months of age and eventually becomes an extremely minor component in the adult red cell. HbA is the predominant form in adults with very little HbA2. In the following slides, we will see how these relative percentages change in various disease states. Hemoglobinopathies can be divided into qualitative and quantitative defects. Qualitative defects are usually inherited as autosomal recessive traits with normal to near normal globin synthesis. However, their overall function is defective. Quantitative defects are a result of decreased globin synthesis, such as those seen in thalassemias. Qualitative alterations most commonly affect the beta chains, but can occur in any chain. We use the term disease to signify both globin chains in a pair are altered. For example, sickle cell disease is the result of both beta globin chains in the hemoglobin tetramer being defective. This may also apply to combined disorders such as hemoglobin SC disease, where one beta globin chain has the sickle cell mutation and the other beta globin chain carries the hemoglobin C mutation. The term trait is used to indicate one of the globin chains in a pair are altered. The order in which the alterations are designated actually matters. The first letter signifies the predominant hemoglobin present. So in the example of HbAs, this indicates that there is more Hba than HbS present. This table outlines some of the qualitative hemoglobinopathies that often show up on exams. Hemoglobin S, the basis of sickle cell trait and disease, is the most common beta chain mutation. It results from a substitution of glutamate at position 6 with valine, and is found most commonly in Africa, India, and the Middle East. Hemoglobin C is the result of glutamate substitution at position 6 with lysine in the beta chain. In splenectomy patients, hemoglobin C crystals may be seen, and this type of alteration is common in West Africa and is thought to provide some protection against malarial infection. Hemoglobin E, a substitution of glutamate with lysine at position 26 in the beta chain, results in microcytosis and target cells and is seen in Southeast Asia and Northeast India. Hemoglobin D Punjab is a glutamate to glutamine substitution at 121 in the beta chain, mostly seen in India and Pakistan, but also in some Eastern European countries as well as Turkey. Hemoglobin Lepore is actually a fusion of part of the delta and beta genes, often seen in the Mediterranean regions, and can result in microcytosis. The fusion gene is under the control of the delta globin promoter, which is not an efficient promoter, and this leads to a decreased production of hemoglobin Lepore. So hemoglobin Lepore is actually more of a thalassemic hemoglobin variant, but I've included it here within this list for ease of reference. Hemoglobin O Arab is a beta chain substitution of glutamate for lysine at position 121 and is quite rare. Hemoglobin G, which is the most common qualitative alpha chain mutation, resulting from an asparagine substitution for lysine at position 68, is seen mostly in Africa. On the left is an example of hemoglobin C crystals, seen both extracellularly and intracellularly, as well as target cells in the background. On the right, we see examples of sickle cells. Thalassemias are a type of quantitative alteration. I will only briefly be covering thalassemias here. Remember that alpha globins are critical for adult hemoglobin. There are 4 globin genes, and because of this, we don't really see clinically meaningful presentations until at least 2 of the 4 genes are absent, resulting in an alpha-thal trait. When the 2 absent genes are missing from the same chromosome, we call this a cis deletion, and this is more commonly found in Asian descendants. When the 2 deleted genes are from different chromosomes, we call this a transdeletion, and this results in a milder form of the disease and is found much more commonly in African descendants. When 3 of the 4 alpha genes are deleted, hemoglobin forms beta globin tetramers, and we call this HbH or hemoglobin H disease. This presents with hemolytic anemia. With a loss of all 4 alpha globin genes, the developing fetus has no choice but to make gamma globin tetramers. We call this hemoglobin Bartz, and this is incompatible with life. This results in hydrops fetalis and stillbirths. Beta thalassemia is common in Mediterranean and African regions and comes in both minor and major forms as a result of either diminished or completely absent beta globin synthesis. Diminished synthesis is designated with a plus sign, and absent synthesis is designated with a null sign. Beta thal minor, or trait, is the result of beta plus or beta null in one of the beta globin genes. These are often clinically silent or have very mild symptoms. Beta thal intermedia is the result of both beta globin genes being affected, either as beta plus or beta plus, beta null. These patients tend to have moderate symptoms. And finally, beta thal major, which is a complete absence of beta globin synthesis and severe clinical ramifications, such as failure to thrive and extravascular hemolysis. I've included in this table here on the right what you would expect to see on hemoglobin electrophoresis. In beta thal minor, hemoglobin A2 will increase slightly to around 5%, and fetal hemoglobin will slightly increase to above 1%. In beta thal major, there would be virtually no hemoglobin A, and fetal hemoglobin would constitute the majority of the hemoglobin types seen. This is a geographic representation of the distribution of hemoglobinopathies we've discussed so far. One of the methods used to detect hemoglobinopathies is high-performance liquid chromatography, or HPLC. Remember, HPLC is used to separate compounds based on their polarity. For pathology in-service and board examinations, you should know where the different hemoglobin types elute on HPLC. And I've included them for you here. I have also included the normal percentages of the usual peaks found in an adult on the bottom right. The way I remember the elutions is by the mnemonic iron 2 disco. Another way of writing it out is here. The 1 indicates hemoglobin A1C, the 0 indicates hemoglobin A, and the 2 indicates hemoglobin A2. The 2 also stands for the reduced ferrous state of iron, Fe, which is separated by the numbers. This is then followed by D, S, C, and O. This is how I remember it, and is probably complicated for some. Another mnemonic that might help is one cattle farmer acted to embrace disco. Now, obviously this may not work for all, but whatever works for you, use it. You do have to know in what order these hemoglobin variants elute. There are just a couple caveats to know about this. Hemoglobin E tends to run with hemoglobin A2 and is impossible to separate. And in most HPLC systems, hemoglobin Lepore will also elute with A2 and should be suspected if the A2 peak is wider than usual or if it shows a double peak. Some exam questions may give you a percentage of this peak, and if it is close to 15%, they're probably pushing you to pick hemoglobin Lepore. Lastly, HPLC does not provide accurate quantification. Now let's practice some of these concepts. What would you expect these results to be? These are normal HPLC results. Normal adults have minimal A1C and A2 and are predominantly hemoglobin A. What do you see here on the right and left? On the left is sickle cell disease, where we have a complete absence of the normal A peak, and almost all our hemoglobin eluting within the S window. On the right is sickle cell trait, where we still maintain the majority of our hemoglobin as hemoglobin A, but there is a significant increase within the S window. And here, the left image shows hemoglobin C disease. Again, we are missing our A peak, and the majority of our hemoglobin elutes within the C window. And here, hemoglobin C trait, where we have maintained the majority of our hemoglobin as hemoglobin A with a significant amount in the C window. Here's an example where the percentages for each peak are provided. So what do you think these HPLC results show? This is beta thal minor. Remember, I said earlier that beta thal minor will reveal a minor increase in A2, around 5%, where normally it would be less than 3%. Fetal hemoglobin would increase slightly above 1%. The percentages provided in the table above the peak are most consistent with beta thal minor. Feel free to pause the video to give yourself time to think about the following cases. This is an example of sickle cell trait. Again, we have a peak in the S window, over 30%, and the majority of our hemoglobin elutes within the hemoglobin A peak. Pause the video if you need more time. This one is a little more involved. First, we have a prominent peak in the S window, so we know we must have a hemoglobin S. Our A peak is absent, with a prominent F peak and a slight increase in our A2 peak. These results would be expected with beta thal major. However, in our case, one beta globin gene is hemoglobin S, and so this would be most consistent with a combined beta thal and hemoglobin S. The combined beta hemoglobinopathy accentuates the beta thal results we would have seen had it been the sole defect. These results are consistent with hemoglobin E trait. Remember that hemoglobin E cannot be separated from A2 on HPLC. And lastly, here's an example of HBE disease. I have included a few more plots for you to study on your own. Pause here if you wish to review them now. Hemoglobin electrophoresis is easily testable material and can be confusing starting out or if you're not doing them regularly. So I'd like to go over how I approach electrophoresis here. Remember that hemoglobin electrophoresis can only be reliably interpreted in the setting of normal iron levels. Patients' iron levels must be replete before electrophoresis is performed. For electrophoresis, red cells are lysed and the hemoglobin is concentrated prior to loading the sample onto the gel. We will start with cellulose acetate gel electrophoresis, which is performed at pH 8.4. At alkaline pH, hemoglobin has a net negative charge and will migrate towards the anode when a current is introduced into the system. If a hemoglobin amino acid substitution is present, this will alter the net charge and thus its migration on the cellulose gel. These migration differences are grouped as shown in the image on the right. So for example, HBC and HbA2 will reveal the same banding pattern. However, HBC and HBD will show different banding patterns. One way to remember which hemoglobin type falls under which band is by the mnemonic ACEO went to San Diego for audits. A2, C, E, and O move together. They fall under the same band. S, D, G, and Lepore fall under the S band. F and A are their own separate bands. Hemoglobin C Harlem will move with C on cellulose. In an attempt to separate out the groups from cellulose at pH 8, we run a second gel on citrate agar at pH 6. The citrate agar at pH 6 separates the different hemoglobin types based more on their structural variations rather than their charge. Notice here that the origin is actually in the middle of the gel. This second electrophoresis allows us to separate D, G, and Lepore from S, E and O from C, and C Harlem from C. It will not help us distinguish D, G, or Lepore from one another as these migrate with each other on both cellulose and citrate. The mnemonic to remember for citrate at pH 6 is cracked skin and aged folks, with and signifying the origin. C and S run in their own bands towards the anode. O Arab runs near the origin. And D, G, E, and Lepore run in the A band. The F band remains solitary as before in pH 8. C. Harlem moves with S on citrate, or at pH 6. Remembering where each hemoglobin type falls and where it is grouped on which pH can seem a little hard to remember. Even worse, you may not always have the bands listed for you, and so you may be required to figure it out on your own. One way to simplify this is to remember the shorthand for these electrophoretic bands. Find out what band you're dealing with, then apply the grouping mnemonics we learned previously to sort out the likely hemoglobin type you are dealing with. Now, here is how the shorthand works. There are always 4 main band classes. They always start with C, then S. The arrangement of F and A will depend on whether you're dealing with pH 8 or pH 6. For pH 8, remember minus CSFA plus. The plus at the end designates the higher pH, and the last letter, being an A, is a vowel similar to the first letter in 8. At pH 6, remember plus CSAF minus. The minus designates the lower pH, and the F, being a consonant, is the same as the first letter in 6. Once you've determined which pH you're dealing with, you can use the mnemonics to figure out which hemoglobin types are in the bands you're dealing with. Last note before we practice some of these concepts. Some hemoglobin variants move too quickly to capture on electrophoresis, and so you may need to stop the procedure early or use longer gels to capture these variants. The most notable ones are hemoglobin H and Bart's. Now, let's practice. Let's do this one together to get a feel for the shorthand and mnemonics we discussed. If you would like to attempt this one on your own, pause now. We are given a gel without banding designations and a couple examples. We are asked to interpret the last band on the gel. If we look at the top, we are given the minus sign at the end. Therefore, we must be dealing with a citrate gel at pH 6. The banding pattern of the standard in lane 1, therefore, must be CSAF. We can confirm this by looking at the example provided to us in the second lane of a patient with known sickle cell anemia. The majority of their hemoglobin lands within the S band. There is no A band and very little F. This would be expected from a patient with sickle cell disease. From here, we can eliminate choice A, B, C, and E, and are left with answer choice D. Remember that on citrate at pH 6, band A also runs with hemoglobin G, D, E, and Lepore, but these were not answer choices. Now try to do this one yourself. Pause the video now and resume when you are ready. The answer is B, hemoglobin SC. In this example, we are not given the electrodes, so the way we figure out if we are dealing with CSFA at pH 8 or CSAF at pH 6 is by looking at the example they provided us in lane 2. We know we are dealing with a patient who has sickle cell trait. We therefore would expect one band at S and one band at A. From here, we know that the standard in lane 1 has to be CSAF, and the gel is a citrate agar from pH 6. The problem here, though, is we are not given the position of the anode or the cathode, so we do not know if the gel has been flipped horizontally. By convention, gels would be read from left to right, or CSAF in this case. But with the knowledge at hand, FASC is also a possibility. Fortunately for us, None of the answer choices would fit having bands at F and A, and therefore we must be dealing with the correctly oriented gel CSAF. Remember also that normal and hemoglobin disease states would produce only one band, so we can eliminate answer choices C, D, and E. Combined hemoglobin S and beta thal would produce a strong F band and an S band, which would not fit in lane 3, whether the orientation was CSAF or FASC. Therefore, the answer has to be hemoglobin SC. Feel free to pause the video now. The answer here is D, hemoglobin H. If a normal patient sample is provided, use it to orient yourself. We are given a normal patient sample in lane 4, consistent with CSFA banding patterns on this gel. Notice that the band of interest is running a little bit faster than the rest, and this is our clue that we might be dealing with one of those faster variants. On the list of answers, the only ones that move fast are Bart's and hemoglobin H. Since Bart's is pretty much fatal in utero, the answer has to be hemoglobin H. Pause here and resume when ready. We need to remember our mnemonics to figure out what the traveling partners are for each band at pH 8 and pH 6. Based on the cellulose gel above, we know we are probably dealing with a trait, since we have one band on A and one band at S. We also don't have a C band on either gel. We can therefore eliminate options A, B, and C. Remember also that O Arab will move near the origin on citrate, and that is not the case here, so we can eliminate F as an answer choice as well. At pH 8, nothing runs with A, while D, G, and Lepore all run with S. At pH 6, we have lost our S band and now have a prominent A band. On citrate, D, G, and Lepore run with A, and of course E, but that is not an option here. So how do we reconcile these three that move together? If you recall, Lepore is found in Mediterranean descent, and hemoglobin D is found primarily in South Asia, Turkey, and some areas within Eastern Europe. Our patient is of African descent, making hemoglobin G trait the most likely option. The hemolysis seen on the peripheral blood smear was meant to throw you off, and is likely the result of a mechanical valve given his cardiac history. The last thing I want to discuss is solubility testing. This is a screening test for hemoglobin S. The idea behind it is that we initiate precipitation of hemoglobin S using sodium hydrosulfate. This precipitation of abnormal hemoglobin out of the blood obscures our visualization of lines behind the tube, resulting in a positive screening result as seen in the image. The problem with this test is that you may initiate precipitation of other abnormal hemoglobins that are not hemoglobin S, such as hemoglobin I or even C. Harlem. And so you must follow this up with HPLC or electrophoresis to reconcile these false positives. And that's it. Hope this was helpful.